All right. So thanks everyone for joining today. So as I said, we're going to talk about antimicrobial resistance, this wicked problem that we're facing, and why this really requires a health systems approach. I'm just going to open the chat here as well. In case anyone wants to put questions into the chat, you can feel free to do that. There should be time for questions at the end as well. Okay, so I guess I could introduce myself too. I'm Jason Vanstone. I'm a research scientist with the Stewardship and Clinical Appropriateness Department. I work with our Provincial Antimicrobial Stewardship Program. I'm based out of Regina, here at the Regina General Hospital. So where I like to start with this is just going back to, this whole idea of the interactions between bacteria and people. So as long as there have been people on Earth, there have been bacteria around to infect us. They are much, much older organisms than we are on the evolutionary scale. And so that's an important piece to understand. The bacteria have been with us since the beginning, and it's something they have had an effect and an impact on human life throughout all of history. So I happen to have a favorite bacterium, and I'm sure many of you do as well. You can throw it in the chat if you want to, if you have a favorite bacteria. But this one is my favorite, Yersinia pestis, and it's this is the bacteria that causes the plague. So for any of you familiar with it, I find it fascinating, all the history of the plague, and especially the Black Death that swept through Europe in the 1300s. It's just such a fascinating study in, what can happen to a society when an illness, an infection like this essentially sweeps through and wipes out, half the population in a matter of years. So it's a very interesting bug, and it's very interesting the impact that these things can have on human culture. So it's some of the, if you look back as far as even 5,000 years, we have evidence of the plague infecting Europeans in this case. So this is from an article about a grave site, a mass grave site that was found in Sweden. And it's a Neolithic era grave site, so about 5,000 years ago. And in this mass grave, they found the bones of a 20-year-old woman with evidence that she had died from the plague. So you've got these really old, Neolithic farming communities, and we were finding people dying of the plague even at that point. One of the things that I think is really neat is how these diseases make their way into our culture. So this is a picture called The Triumph of Death by Peter Bruegel the Elder, painted in 1562. So keep in mind, this is like 200 years after sort of the height of the Black Death sweeping through Europe. But if you really get a good look at that, you can really start to pick out sort of the, I think, monumental impact that something like the plague had on the European population at that time. So you can see, just, obviously dead people everywhere. There's armies of skeletons and, hauling bodies through the streets. There are royal people down in the corner here. Like, no one was safe from this. There's cities burning in the background and the dark, bleak sky. So again, if you really think about, half of the population getting wiped out in over a course of within a decade, think about the impact that would have on our society today, right? And so same thing back then. So this was a big thing, and like I said, it's made its way into our art and culture. We talk about avoiding things like the plague, and so it's something that these little tiny organisms, these little tiny bacteria, have had a huge effect on people, and not just our art and culture, but our ability to be alive. So here are data from the US showing the amount of deaths in 1900 on the left from infectious diseases. So just over 100 years ago, about 46% of the people who died from an infectious disease, which I think is a pretty staggering stat, especially when you consider that now in 2010, that number is down to about 3%. So that is a huge shift in terms of almost half the people dying from an infectious diseases cause down to only about 3% in just over 100 years. And if you overlay a life expectancy graph on that, so back in the early 1900s, you could expect to live to about 45 years. That was life expectancy. Now that's up over 80 years in a lot of places around the world. So this almost doubling of life expectancy as well creates a huge, again, just change in what people are dying from and how long we can expect to live. So Obviously, in that century, there's a lot of advancements that have come along in terms of medical science and sanitation and those kinds of things. But when we're talking about infectious diseases, one of the big things that took part in this shift is the discovery of antibiotics. So this is a cool little story that I love. I think it's one of those examples of where you have basically an accidental discovery that really changed a lot for humanity in terms of, especially in the medical world here. So our first antibiotic discovered was discovered by the man shown on the left there. So that's Sir Alexander Fleming. He was a bacteriologist working in the early 1900s in the United Kingdom. And he was notorious for having a terribly messy laboratory, things everywhere. You kind of get a sense of that from the picture there that he's in. And so the discovery of penicillin is this neat little story where he leaves his laboratory to go on vacation for a week and comes back and realizes that he's left one of his plates of bacteria open. So this petri dish that you see on the right here might be an example of that. So you've got the petri dish itself, the jello stuff on there, the agar that the bacteria, it's great bacteria food. And then this gray streaky stuff here, that's the bacteria growing. And what this is a fungal colony. So he realizes that he's left his plate slightly open and this fungal spore has come in and landed on the plate, and it starts growing because fungus love to eat that stuff too. But what he notices is, there's this area between the fungus and the bacteria, and he goes, isn't that interesting? And he looks more deeply into this and discovers basically our first antibiotic. So you've got this penicillium fungus growing, and he discovered this chemical that is extruding that he termed penicillin, and that is the chemical that's killing off these bacteria. So what happened here, he stumbled upon this chemical warfare that's going on in the microbial world. So if you think about evolution and natural selection and all those sort of concepts, every living thing on earth has to fight for its place to survive, right? So in animals, we do this with teeth and nails and claws and things like that. Bacteria, fungus, they don't have that, right? So they use chemicals. So the penicillium fungus releases this chemical that we call penicillin into the environment, and it kills off those bacteria. And now that fungus has all that space to live and spread and eat all that food that's there, and the bacteria can't get at it. So this was 1927 when this discovery was made, and it was 1942, 43-ish when we really first started using antibiotics more broadly in the public, especially during World War II. We were using them a lot to treat soldiers who were coming back from the front lines with really nasty wounds that were infected. But we were able to start using this drug for medicine to actually treat people and prevent them from dying from these bacterial infections. And so this kicked off this explosion, if you will, of discoveries of different types of antibiotics, different classes of antibiotics. And so you can see they're just listed here along that sort of timeline throughout the 20th century there, but different classes of antibiotics being antibiotics that work in different ways. And so this was great. I mean, it was the golden era. We found all these things, and we were able to start treating all these infections that people would have that, as you saw, would normally be killing people about half the time. And now we were able to start saving them from that. So that was fantastic. But then, of course, there is the other side of that. And so there's this idea of antibiotic resistance. And so really that's what this Awareness Week is all about, is trying to make people aware that this is an issue and this is what we need to be tackling globally. So antibiotic resistance, if you have your regular old run-of-the-mill bacteria, these guys here, and you throw antibiotics at them, they die. When you look inside the bacteria, there's a simplified version. So they have their main chromosome, that's all their DNA. They'll have these, often we'll have these extra little pieces here called plasmids. So these are extra little pieces of DNA that bacteria have. And these can actually be quite important in the antimicrobial resistance world, because this is often where some of these antibiotic resistant genes will reside, and then they can be shared quite easily among bacteria. But so you've got these regular guys, they get killed by the antibiotics. The only difference between these bacteria and antibiotic resistant bacteria is genetic mutations. So this is a naturally occurring process where these guys can develop these mutations that makes them resistant to the antibiotics that are being used by the other microbes around them to try to kill them. And so that, because this is a genetic thing, that's what can make this very difficult for us to tackle this issue of resistance. Bacteria grow really quickly, they can share those genes really easily, and so we can see the development of antibiotic resistance happen very quickly, and it can spread very easily amongst populations. And so to exemplify that, there was this really neat experiment that was done at Harvard a few years ago, or I think it was in the middle of the 2015, somewhere around there. And this, what's showing here on the screen is a time-lapse image of essentially a giant petri dish. So you have a petri dish that's like the size of a table, and they put the agar in there, and what they did was, going from the outside towards the inside, they increased the concentration of antibiotic. So on the outside here, you have no antibiotic, and then there's a 1 times concentration in this column, and a 10 times in this column, and so on and so forth, until you get to the middle there, where there's 1,000 times concentration of antibiotic. And so when you plate the bacteria, they grow right up to that edge of the plate on both sides here, where you will have the antibiotic start. So the bacteria can't grow any further unless they've developed antibiotic resistance. And so you can see these sort of conical shaped, I'm just going to speed it up here so you can see it a little better. You can see these sort of conical shaped progressions of bacteria growing into higher and higher areas of antibiotic concentration. And so each of those represents, 1 bacterial cell developing or gaining antibiotic resistance, and then all of its progeny growing into the next area until they hit that next wall of increased antibiotic concentration, in which case we need to further that resistance before they can grow again into the middle. And so if you put one of these neat little evolutionary trees over top, you can then trace the ancestry of the bacteria in the middle here all the way back to their great grandparents all the way back at the front, basically saying these guys are 1,000 times more resistant to antibiotic than their ancestors all the way back here. And this took it was about 7 or 10 days for these bacteria to grow. So in a matter of a week, we're seeing bacteria that are 1,000 times more resistant to antibiotic. And so that's kind of scary, right? When you think about how easily this can grow and spread through bacterial populations. And then if those bacteria are infecting people, that creates problems for us. So this idea of antibiotic resistance is not something new. And in fact, when penicillin was introduced in, first being used in 1943, we already knew at that point that there was antibiotic resistance. So that's what these things here, the star shape is the discovery of resistance, and the pill is when we first start using the antibiotic. So 3 years before we started using penicillin, we already knew there were bacteria that were resistant to it. But what this sort of timeline here shows is that any antibiotic that has been introduced, it's only a matter of time until we start to see antibiotic resistance. Sometimes we're lucky and we get, 10, 15 years out of it. Sometimes it happens much sooner and we start to see resistance much sooner. And this has happened with every antibiotic that we've got, and it will continue to happen with every antibiotic that we will get in the future, because of this idea that this is just a genetic mechanism. Then eventually these bacteria will find ways to become resistant to these different types of antibiotics. Once that resistance has made its way into a bacterial population, then it's just a matter of time for it to start spreading around the world. So the data on the right here are showing the spread of antibiotic resistance, or the number of samples around the world that have antibiotic resistant bacteria over time. So just going from 2000 to 2012 here, and you can see there's different types of antibiotic resistance, fluoroquinolones, aminoglycosides, so on and so forth. But eventually over time, these things all start to increase. And so this is the problem that we're facing. And I don't want to leave the impression that this is just a global problem in places elsewhere, because it is absolutely an issue for us here in Saskatchewan. So this is an example of a patient that was in the hospital earlier this spring, grew something in their lungs, and it was resistant. This is the lab report showing that the bacteria that were growing were resistant to every single antibiotic we had on hand to try to treat that patient with. So this is a very real thing that we are seeing in our hospitals, in our communities, where people are getting these, in this case, pan-resistant infections, bacteria that are resistant to everything we have to throw at them. So that's a problem for us, and that's what we're trying to fight against here in terms of being aware of antimicrobial resistance and what we can do to fix this problem. So on that, this is an example of one of those things that's trying to fix this very issue here. So there is this McMaster Antibiotic Access and Capacity Project. So it's a collaboration between one of my favorite organizations for their name, only the cake, the Canadian Antimicrobial Innovation Coalition, and McMaster University. So what they're trying to understand is how can we improve access to antibiotics? So it's not that there aren't new antibiotics out there, but getting access to those isn't always easy. And so one of the figures from their report here shows Canada at the bottom in terms of our access to 18 new antibiotics that have come out in recent decade. So you can see at the top of that list there, the US has access to 17 out of the 18, and there we go all the way down until Canada. So for many and varied reasons, Canada has access to very few of the new antibiotics that are coming out. So that's something that we need to address nationally. We need to make sure that we're able to get these things in Canada so that patients have access to new things, so that hopefully when we're seeing cases like this, there's something novel there that we can use to help treat these patients. So one of the questions then is about what drives this antibiotic resistance. How do we see this happening? What makes this an issue for us? And I'll just make the point with this slide that basically the more antibiotics we use, the more antibiotic resistance bacteria we are going to see. So it's our use of antibiotics that's driving this. And so these data here, again from the US, show the seasonal variation in penicillin use in this case. So we've got high use in the blue in the winter time, which makes sense in North America. We've got cold and flu season. Lots of people are going to the doctor, getting prescriptions, whether or not they need them. And then we see a reduction in the summer months. It's nice outside. People spread out, go out, do things, be healthy. And then we get back to the fall. Kids are back in school and they're gross and they cough and sneeze all over each other. And flu season starts off again and we see more antibiotics. So we see this up and down cycle in most places in the Northern Hemisphere where you have high antibiotic use in the winter, lower in the summer, and then back up again as we get into the winter. What's neat about this data, though, is these guys also looked at resistance to that antibiotic in bacteria. And so when you have high use in the winter, we see there's about a 1 month lag between the peaks, but you then see high antibiotic resistance in those bacteria. And as we use fewer antibiotics, we see less antibiotic resistance and then back up again. So we know that we can affect the amount of resistance we're seeing in bacterial populations just by how much antibiotics we use. So the question is, how much antibiotics do we use? And this is some neat data from the Canadian Antimicrobial Resistance Surveillance System, or the CARS system, and they release a report every year. And I really like this one that they did in 2021 because it really exemplified where we have room to improve in Saskatchewan as a case example. So what we're seeing here across the bottom is the provinces and territories across Canada. So BC and the territories are combined together here. Alberta, Saskatchewan, Manitoba, so on and so forth, going eastward. And what we're looking at is the defined daily doses. So basically the amount of antibiotic being used based on the per 1,000 inhabitants. And then each bar within each province represents one of the years that they had collected data for us. So from 2015 through 2019. And the point here is that you can see for Saskatchewan, for every year on record here, we used more antibiotics than all of our neighboring provinces. And in fact, they used to combine the Atlantic provinces together here into one, and that gave us the silver medal in Saskatchewan across Canada. So we use the second most antibiotics out of every other province and territory in the country, which is not a silver medal we want to have. And to me, this indicates that we have a lot of room to improve our appropriateness of our use, how many antibiotics we're using, and therefore decrease the amount of antibiotic resistance we might be seeing by being more appropriate with those antibiotics that we are using. So that's why we have antimicrobial stewardship. That's why people like myself have a job, to try to ensure that we're using antibiotics appropriately, promote this information across the province and wherever else we can get a platform. But when we ask people, what is antimicrobial stewardship? this is often the response that we'll get is, I don't know, and it's, people often can't even say the words, let alone describe what exactly it is. So I like to take the approach of describing this. I'm a big board game fan, for anyone who knows me, and Pandemic is one of my favorite board games. And I think this game really illustrates what antimicrobial stewardship is. So let me describe for you for a second here what the game is. The Pandemic board game, this is the board, and it's a map of the world, and you've got these 4 different diseases that are doing what diseases do, trying to take over the world, kill all the people. So you've got these red cubes and black cubes and blue cubes and yellow cubes here, and those represent the different diseases. And the players, which are represented by these little player pawns, have to go around and try to find cures for the different diseases. That's what these little vials are down here. And so this is a cooperative game. So it's one of those games where the players play against the game. And so you win together by beating the game, or you lose as a team if the bacteria kill all the people. And so what's neat about it is everyone on the team gets a unique role. So they'll get this card that gives them a special ability that nobody else has. But when you merge all those special powers together, that's what gives the players the advantage against the game. But of course, the game doesn't just sit back and take it. So there will be things like epidemics or mutations that will happen that will change the way that these diseases can spread. It makes it a bit more unpredictable, and that's where the challenge comes in for the players. So what I like about this, as I said, is it's similar to what we do in antimicrobial stewardship. So just like the players in the game, an antimicrobial stewardship program is a multidisciplinary team of experts. So we've got people with different backgrounds, different education, different things that they bring to the team. And our job is, in this case, to try to slow the development of antimicrobial resistance around the world, here in Saskatchewan, by promoting the appropriate use of antimicrobials. So just like in the game, you're trying to stop these bacteria, these viruses, things from taking over and killing everyone. We're trying to do something similar here by ensuring that we have antibiotics for generations to come, that all people can benefit from these, medical miracles that we've discovered just in the last, 80 years or 100 years. So let's kind of look at this in the numbers. So what is antimicrobial resistance? Like, how big of a burden is this for us? There was a report that was released in 2019 from the Council of Canadian Academies, and there have been similar reports done around the world to look at what the size of this problem is in their local regions, and what the potential effects might be if we don't get a handle on it. So this was the Canadian version, and it was entitled "When Antibiotics Fail." And that stuck with me because it wasn't what if antibiotics fail, it was when. So this is scientists and experts who tend to not be, catastrophic when they're saying these things, because they really want to let the data lead. But so that struck me, that they actually titled this "When Antibiotics Fail." This is something we're going to have to deal with. How can we, make the most of the time we've got with these things? And so some of the stuff they did, they just looked at, what's going on in Canada. So in 2018, which was the data set they were looking at, we had about 980,000 bacterial infections in Canada. And of those, just over a quarter, so about 250,000, were resistant infections. So people who were infected with a bacterium that was resistant to at least a first-line antibiotic. And so then when you take those resistant infections and break it down, of that 250,000, about 14,000 of those people died. So that's the red piece of the pie here. And of those deaths, 40%, 4 in 10 of those people would not have died if the infection was susceptible to first-line antimicrobials. So we have a large number of people dying from things that they shouldn't have to be dying from if we're able to treat them appropriately with antibiotics. And so they, this is the what happens sort of thing. So they did a few different models here to try and predict what this could look like. So first, looking at that population decline, number of deaths. So currently, with that about 26% of our resistance rate, they're looking at population decline. So 2018, that was 5,400 deaths. By 2050, we could be seeing 7,000 deaths a year, which would be 256,000 cumulative deaths. And so that's the status quo. That's if nothing changes about our resistance rate, it doesn't increase or anything like that. Their next model was 40% resistance rate, and that they actually considered to be highly plausible. So this wasn't like picking a number out of the air. It was like, what happens when this gets to 40%, which we expect to happen by 2050. That would be 13,700 deaths a year for a cumulative total of 396,000, and 140,000 preventable deaths if we had been able to keep it at 26%. And then the 100% is the worst case scenario. So let's say that there are no bacteria that can be treated anymore. We're looking at, over 500,000 people that would be dying that we would be able to prevent if we kept the resistance rates low. So that's the cost in human lives, right? But they also looked at GDP. So for anyone who's more interested in money than people, they did some math for that too. And same idea, you can see how much this costs our GDP in terms of lives lost and hospital bills and all those kinds of things, looking at hundreds of billions of dollars in potential GDP loss just by seeing increased infections. So this really is, as I said, with the case of the plague, this is something that affects all of society. There's a lot of money that goes into hospital care for people with antibiotic resistant infections and things like that, not to mention, the lost productivity of people dying younger than they need to. And so a report from the UK predicted we would see more than 10 million deaths per year from AMR around the world by 2050. Not a burden shared equally. Something we're still all going to have to deal with, because as we know, these things don't just stay wherever they develop, they move around with people and infect others. But to put that number in context, what is 10 million deaths a year? So right now, around the world, about 1.3 million deaths a year from AMR. But we see about 10 million deaths a year from cancer, much more prevalent, and something that I think a lot of people, especially in places like North America, relate to, because a lot of people in an aging population know someone who's been affected by or has died from cancer, but relatively fewer people know someone who's been affected by AMR. So if we see that 10 million number come to light, we would see as many people dying from antimicrobial resistance as we currently see dying from cancer. And to me, that's just not a place we want to get to in terms of medicine. We don't want that to be a new reality for us. And that's 25 years from now, not that long into the future. And so what that indicates to me is that shift that we saw from half of the people dying from antimicrobial resistant infection, from infectious diseases, going down to 3%. We start to see that line going back the other way. So here that is in sort of a timeline. There is our infectious disease deaths with the spike of, the flu pandemic in 1918 going down to this, 3% mortality. We would start to see that line going back up the other way if we're seeing these predictions coming true, or these models coming to reality. In terms of number of people dying from now antimicrobial resistant infections, as opposed to just the regular old infections. And just for clarity, this is not real. That's just me drawing those lines in, but just to illustrate a point. Okay, so what's being done? And we are doing stuff about this. How effective that is, we can debate, but I'll start with the global picture and move a little bit more local. So the Global Action Plan on Antimicrobial Resistance was released by the World Health Organization in 2015. So this was the first sort of global document to be like, we need to do something about this. This is a problem for all of us. And so back in 2015, they had 5 objectives. We need to improve awareness and understanding of AMR through effective communication, education, and training. Things like this. Strengthen the knowledge and evidence base through surveillance and research. So we need to know what the rates of AMR are in different places, how we can tackle that. Reduce the incidence of infection through effective sanitation, hygiene, and infection prevention measures. So a lot of that just reducing that upstream work of reducing infections in the first place, so we don't need to treat people with antibiotics. Optimizing the use of antibiotics in human and animal health, so making sure that we're using these drugs only when necessary, using the right dose, the right duration, the right route, those kinds of things. And then developing an economic case for sustainable investment that takes account of the needs of all countries. So we can increase investment in new medicines, diagnostic tools, vaccines, and other interventions. So getting everyone on board, accounting for differences around the world, how we make this better for everyone. One thing that I really liked about this action plan was really taking that One Health approach. So they talked about how this isn't just something we do in human medicine, but we need environmental health, we need animal health to be on board with these things too. And really pushing the point that this is an all-out effort that is needed. It is not something that we can do in one place in the world or one sector in health. This is everyone on board, all hands on deck to really come together to tackle this problem. So I just want to take a minute because I mentioned One Health, and this is an important concept in antimicrobial stewardship. So there's this One Health triad. So for anyone who's not familiar with it, it's this idea that the health of humans, animals, and the environment is connected. So anything that happens in one sector will eventually bleed into and affect the other sectors. And so in the same way, anything that we do to try to tackle antimicrobial resistance in humans is only addressing part of the problem, because if we're not dealing with it in animals or people, we're going to see those resistance genes continue to make their way into the bacteria that then infect human populations. And so there's this great figure here from this Pan-Canadian framework, which we'll talk about shortly, that kind of illustrates this. So you've got, obviously, in the human world, spread between humans. Like I said, we cough and sneeze all over each other all the time. But then those antibiotic resistance genes and the bacteria can transfer between us and animals, going through the food system or through our companion animals and things we live with on farms and things like that. In the animal world, there's the reservoirs in the wild populations of animals, but especially concerning for us is the sort of agricultural world and that close connection between humans and animals. And then, of course, both of those interact with the environment. We flush things down the toilet, we fertilize our fields with animal manure, we dump chemicals containing antibiotics into the environment, and so these things all have an effect on that the natural environment as well. So that's this idea of the One Health approach. We have to do things in all of these areas in order to move forward on this. It can't just be a single pillar that is trying to deal with this. Okay, so from 2015 with that Global Action Plan, the United Nations in 2016 adopted this political declaration. So they had this high-level meeting on AMR. And I think this was the fourth time in history that the UN had a meeting about a health topic, and it was for antimicrobial resistance. And so this was basically getting people from around the world to come together and say, this is a problem, we need to do something about it, we cannot ignore this. And for anyone who follows along, they actually just had a second meeting just back in September. And I'm going to hopefully be writing up something about that in our upcoming 5-minute update here, so you can check in on what the results of that meeting were. But they are keeping up on this. So out of that work came or following that work, I guess, came this monitoring and evaluation of that global action plan on antimicrobial resistance. So I'm not going to go into all the details here, but basically it was, the WHO saying, obviously we can't just have a plan, we need to measure what's working, what's not. And so that was to work over the next, I think, 5 to 10 years there. Wanted to make sure we were getting good quality data from around the world, reduce the multiple data collection that we were seeing and reporting requirements, so we can try and streamline this and make it easy for people. Again, highlighting that everything was done with a One Health perspective, so that we're getting information from all of these different sectors. And the one thing they didn't do in this was set targets. And they did that because, a lot of places didn't have baselines. And then the context about, resourcing and what's available and all those things from country to country is very different. So they thought it would be difficult to set global targets. But this tripartite, so the Food and Agriculture Organization, the Animal Organization, and the Health Organization, did encourage countries and regions to set their own targets so that they can measure what's working and what's not. There was a report on this that just came out a few years ago as well, 2021. So they had data from 115 countries that had responded to, they had these questionnaires that they send out to get information from countries about what kind of things they're doing, and trying to decide if, how have they implemented their action plans and moved forward and things like that. What they saw was that over the past 3 years, advancement has happened gradually. So they were seeing increases in the percentage of countries that had nationwide AMR awareness raising campaigns. and also increases in the training and education on AMR, those national monitoring activities for AMR consumption, or antimicrobial consumption and use, and then the national surveillance activities for resistance. So people were looking at what's happening and trying to implement things. But there was definitely room for improvement. So strengthening the multi-sectoral coordination and collaboration was something they talked about. Promoting targeted AMR awareness raising campaigns. So we can't just kind of do this as, la-di-da background stuff. We really need to be focusing on things and getting the message out there. Increasing the monitoring and enforcement of legislation involving antimicrobials, so making sure that we have policies and laws about how and when and where these things can be sold and used. Strengthening awareness to the essential antimicrobials and diagnostics. So there is this aware list of access, watch, and reserve antibiotics. So those are the things that everyone should have access to these antibiotics to use to treat people and animals. The watch are the ones that we want to use only if we need them, sort of thing. And the reserve are those that we really don't want to use unless they're absolutely necessary. So making sure that we're looking at that stuff and seeing what we're using and how much of it, so we can address where there's room for improvement. And then, of course, strengthening data monitoring and reporting. That's always an issue. We always need to do better about how can we get better data? How can we use that to guide what we're trying to do? So that was this assessment survey that was done, and I haven't seen a new one since. Okay, so that's kind of the global picture. Nationally, we have in 2017 now had a pan-Canadian framework for action. So building off of that global action plan, telling countries basically you need to be coming up with national action plans. So in 2017, the federal government came out with their framework for action. So this is how we're going to move forward. And again, One Health approach was really highlighted here. Collaborations between government, academics, non-government organizations, industry, things like that. So we knew we needed to get all kinds of people together. This needed to be represented across Canada. And so they had started with really the goal of how do we strengthen Canada's ability to combat AMR in a coordinated way across the country. And so they had these 4 pillars around surveillance, making sure we're collecting the data, infection prevention and control, the antimicrobial stewardship aspects, and then the research and innovation. And that was great. So that was 2017, but that was not an action plan. It was just the framework for the action plan. So then after COVID put it on hold, finally in 2023, just last summer, we had the Pan-Canadian Action Plan on Antimicrobial Resistance officially released. Same 4 pillars, they added a new one called Leadership, which is here, but there was 10 priority actions. So basically 2 actions in each of these that were put forward nationally as these are things we need to start doing under these 5 pillars in order to start moving things forward. And I won't go into details on those. You can check them out in the actual report itself. If you just Google Pan-Canadian Action Plan on AMR, you'll find it. What was interesting about that, so that was in the summer of last year that was released, and then last fall there was an auditor's report from the Auditor General of Canada that was released about the Pan-Canadian Action Plan. And again, I'm not going to read through this whole thing, but there was a couple key points. So what the auditor found was that overall the federal government had not done enough to address the growing resistance to antimicrobial drugs to help safeguard the health of Canadians. The plan did not cover important elements, so it had no information about concrete deliverables, timelines, who is accountable for each action, so who's going to do what by when. It didn't have any of that in there, which just leaves it open to interpretation and people saying, we'll get to it eventually. They didn't do enough to improve market access to new antimicrobial drugs, which was something we talked about earlier, and that even with the improvements in data collection from agencies like the Public Health Agency, there are still some gaps that persist, particularly around AMR in vulnerable populations and then in the environment. And then there was no assessment of whether the changes that they have implemented were working as intended for especially some of the things around requiring there where it says requiring companies to report annually the sales of medically important antimicrobials. Has this actually made a change in what we're seeing in terms of AMR or antimicrobial use, things like that? So there was room for improvement. The Health Canada obviously took these very seriously, and so they've started working on progress reports. So they pulled the team back together. And so there was just this summer, I think, as well, this last summer, 2024, an update, a progress report on the Pan-Canadian Action Plan. And so again, I won't go through all the details there. I was lucky enough to get to work on this group, so there's a lot of information about some of the things we're doing in Saskatchewan here included in that report, and then as well as other places around the country. But you can definitely, again, check that out at the website, see what kind of stuff is going on, and see the gaps that we're missing and how we can work on those in each of our individual areas. So provincially, get down from the national scale. So in Saskatchewan, we have an antimicrobial stewardship program provincially. And I'm not going to take credit for everything because there are people across this province and across different organizations who are passionate about this and work in the field of antimicrobial stewardship and trying to tackle this problem of antibiotic resistance. As far as officially funded work goes, the antimicrobial stewardship program pays for these three people you see on the screen. So myself, Kristen, and Mel, who they are the two antimicrobial stewardship pharmacists with the provincial program. And so, I don't say superhero, but some people do. So I'm not sure how that got in there. But what we try to do is, we've been tasked with trying to cover and promote antimicrobial stewardship across the province. And as most of you know who live here, it is a big province and that is a large task. So we do what we can with the resources we have, but really trying to do things like this, providing information, raising awareness. Obviously, Mel and Kristen have a clinical aspect where they, see patients and help ensure that antibiotics are being used appropriately. We have project work. We've got research projects that go on around the province to try to actually make improvements in clinical care. And really getting the public on board here too, having the public understand that this is an issue that we all need to deal with. So there's less pressure on prescribers to be providing antibiotics when they're not necessary. At the end, it's one of those things where we could always use more resources, more people, more money, more time, more, everything. So this is a really important topic because we're now getting, to that granular ground level of like, how do we start getting these things built in to the health system so that we can get the changes we need to then see those higher level changes in terms of antibiotic resistance rates and antimicrobial use, things like that. So one of the things we did recently too is we had a look in the mirror and we said, okay, we've got this Pan-Canadian Action Plan that we signed on to as a province. Our health Ministry of Health representatives signed off on this thing, as they did from provinces and territories across the country. So what are we actually doing to do our part to address those goals and achieve those goals? And so we've started some conversations with our collaborators in the Ministry of Health, and we're looking towards, I don't know, what we'll call it, a planning day or something where we can really do a good once over of what are we doing, what are the gaps that still exist in Saskatchewan to addressing these things that are listed, these goals that are listed in the action plan, and then how can we start to move forward to that. So I'm really looking forward to that work, and I'm really trying to sort through where can we improve and really start to make a difference on a larger scale with some of our efforts. One thing that I wanted to mention too, like government engagement is key with this. So this is, it's a socio-political issue on the level of climate change, right? We need governments to be engaged around the world, here at home, so that they're putting this as a priority in order to have the people in place to then do the work. So there was this great article that was recently released by the Global Strategy Lab. They have this AMR policy accelerator. They do a lot of great work. But it was the quote that from, I think, the presentation that I watched on this was that the war on AMR is not working. And it struck me because, we've had similar messaging around the war on drugs, right? Where we've realized that the things that we're doing are not actually addressing the problem. And so this Global Strategy Lab came up with these 5 principles for governing AMR on as a socio-ecological challenge. So not just thinking this as a medical issue so much, but something that we need to engage more broadly with. And so they've these 5 principles. Number 1 being that there isn't a silver bullet here. There's not one thing that we can do that's going to fix this everywhere all the time. So we have to have that flexibility and be able to adapt and find new things. And that leads to what number 2 is: designing agile and adaptable institutions. And we all know that healthcare, I'll often use the term like it's like trying to steer the Titanic when you're trying to make a change in healthcare. And that puts us at a disadvantage for things like this, where we have to be adaptable, we have to be able to change and maneuver quickly. So we need to have systems that are, and not just health systems, but political systems and more broadly, that are agile and adaptable to fight something like this. Diversifying practices. So this speaks to that multidisciplinary approach to stewardship itself, right? Having lots of ideas, new ideas at the table, new ways of thinking is a great way to be able to start moving forward and finding, unique ways of dealing with things, or adapting where we need to. Number 4 is creating a living evidence base. So really trying to understand, having a robust evidence base, what is working, what isn't, how we can tackle this. That's what really helps. And then having that, updated and change over time, so it doesn't get stagnant. We can't just put in research, resourcing into research and innovation and then stop and go from there. We need to continually do that. And then involving stakeholders. So this is something that, as I've said, I think a lot here, we need the public involved. We need leadership in the health system involved. We need political will involved in this so that we can move these things along. And so all of those folks have a seat at the table and have a stake in this, so that they understand the importance of why we need to do this. Okay, let me get off my soapbox. So what is at stake? So this is the thing where I try to help people understand, why do we need to do this? And I went to ChatGPT and I had some ideas in my head from a previous slide I wanted to combine into one image. And so I told ChatGPT, create an image of the immense threat of antimicrobial resistance. I wanted to talk about how it is a problem in medicine, in everyday life, including things like cancer treatments, organ transplant, joint placements, replacements, sore throats, and even gardening, which is a neat little story about the first use of penicillin. But it spit this thing at me, and I really liked it. It's your typical AI image. But as I was looking at this, I was like, well, you know what this thing is looking like a lot to me. And you look at this broken city in the background and this mass of people and, all the bad things that are happening, the doom and gloom, if you will, of seeing antimicrobial resistance become more and more a problem. It reminded me of the picture that Peter Bruegel the Elder had painted, 400, 500 years ago. And I know obviously AI is trained off of these things living in the internet, but it was interesting that it took the same concepts of this dark, doom and gloom sort of scenario, and put that all into the image. So again, just this idea that this is what's at stake for us. We will be seeing more and more people dying from things that are, at this point, at least for the most part, preventable. And so if we're seeing that, that's a real big problem for us. It means when you have cancer, those antibiotics that we would normally use right now to be able to treat those opportunistic infections when your immune system has been wiped out from chemotherapy or radiation therapy, whatever, that becomes much more of a problem. The knee replacements and hip replacements, that's one of our biggest surgeries in Saskatchewan. They're relatively safe because we can provide people with prophylactic antibiotics, so they're not getting surgical site infections. That becomes more of an issue if the bacteria are resistant to those antibiotics. And so you might see an increased risk, and then people have to make a decision. Do I want to replace my knee, or do I just live the rest of my life with a really painful knee, because the risk of getting a surgical site infection is too high? So these are the types of things that we're looking at. There's a lot of things that we do in medicine that rely on antibiotics. And to go beyond that, again, if you're a citizen of the world, the UN has the 17 Sustainable Development Goals, things that we need to do to transform our world. And they are all listed on the screen there, but antibiotics are a prerequisite for a lot of these things to be successful. So there was a neat little paper article that talked about some of this. So poverty, universal health coverage, economic growth, we talked about the costs of rising AMR, and health inequity. All of these things are dependent on having effective antibiotics to treat sick people, to help them be more effective and be productive and have jobs and live long lives and those kinds of things. And I already mentioned climate change, right? So this is just like climate change has been over the last decades. antimicrobial resistance is a slow moving background problem that people don't really pay a lot of attention to until, you know, there's giant hurricanes and the world is on fire and all these things that happen. And it's the same for us. Until we start seeing more and more antibiotic resistant infections that are affecting people's daily lives, it's hard to get people to understand and pay attention to this sort of thing. But this is what we're sort of looking at, is this scale of a problem where this is something that will affect the health of people around the world globally. And so we need to be doing our part to get ahead of that. Because while we've been chipping away at climate change for decades, I don't think we have that same time available to us for antimicrobial to fight off antimicrobial resistance. 2050 is not that far away, and if we're seeing 40% of our antibiotic or of our bacterial infections are antibiotic resistant infections by that time, that's a problem that it starts to become too little too late. So we really want to deal with this thing now while we can. So I will stop there and leave some time if there are any questions. If you want to get a hold of us in the Provincial Stewardship Program, that's our email address there. And you can scan the QR code and that will take you to our website, I believe. And I'm always happy to answer questions by email if you have them too.